Yeah. Good morning, everyone. There was some technical hitches, so sorry for that. At the outset, I thank the organizing committee for giving this topic for delivering the lecture. I am pitching in for Dr. Namrata Madam, who was not able to give this lecture because of her personal reasons. So, greetings from Kidwai Memorial Trust College. Here, the place I work. So, navigating the anesthesia in the era of neoadjuvant therapy. So, navigating means you need to go through past the cancer, the therapies, the era, it's a period of era of cancer. We know that cancer is very rampant and is occurring each because of the early diagnosis and treatment. So along with that, the treatment modalities have changed and it is becoming more and more common for us, for as anesthesiologists, to see the patients coming with neoadjuvant therapy for surgeries. So globally, the estimated cancers are around 20 million new cancers, and the deaths are almost 10 million. And the report was latest was 2024. And the WHO predicts to be that it is an increase of 77% in new cases by 35 million by another 25 years. And the most common cancers being the breast, lung, colon, rectum, and prostate. So this is about my overview about my topic of how I'm going to deal with this topic. So historically, the surgery was the treatment for the cancers, and along with that, the new anti-cancer therapies, the chemotherapy, radiotherapy, and immunotherapy have been introduced and adjuncts for less radical surgery. The main treatment would be to decrease the burden on the tumor so that neoadjuvant therapy decreases the size of the tumor and the surgery will be more comfortable or easier for the patients to go on. In 1881, the German chemist, Paul Ehrlich was the first to use chemicals to treat diseases. So following this, the decades, they ensure the discovery of new therapeutic agents with the combination of not in alone, but also in combination, which was a mainstay of cancer treatment. You know that cancer treatment, the anti-cancer drugs, not only acts on the neoplastic cells, but it also acts on the normally dividing normal cells also. This is the reason why you get toxicity when you give chemotherapy. The toxicity is related to the degree of agent what you give, the cumulative dose, the comorbid condition of the patient when he presents with the chemotherapy. Usually they are given in cycles so that you give time period to recover those patients from the post-chemotherapeutic side effects, and also to decrease the resistance and toxicity of the patient. So chemotherapy preoperative, you need to know some terminologies. What are the terminologies? Neoadjuvant therapy. What is neoadjuvant therapy? Neoadjuvant therapy is nothing but you give a chemotherapy to elevate the tumor burden, to decrease the size of the tumor so that the surgery can be comfortable. Perioperative chemotherapy, that is adjuvant therapy, is to decrease the risk of cancer recurrence. Palliative chemotherapy is nothing but to improve the quality of life and prolong survival when there is no chance of cure. So neoadjuvant chemotherapy can be chemotherapy, radiotherapy, or immunotherapy. They can be done alone or in combination. So it is done either before the surgical resection of the tumor. So this is one of the beautiful paper by Amar Bijay, where in anesthesia for neoadjuvant chemotherapy or immunotherapy or radiotherapy. So in this, he delegates how the chemotherapy or immunotherapy will affect the patient, what are the toxicities related to different organ systems, and how they are important for us as anesthesiologists to know this toxicity or what chemotherapeutic agent have been taken and what preparation we need to do prior. So classification of chemotherapeutic agents are done based on your chemical nature and function of the drugs. So we have a number of the chemotherapeutic agents like alkylating agents, your antimetabolites, anti-tumor antibiotics, topoisomerase inhibitors, plant alkaloids, and corticosteroids. So each one of them have a different mechanism of action. Some are given for solid tumors, some are given for liquid tumors like leukemia and lymphomas. But you need to know that what are the side effects of those anti-chemotherapeutic agents. So those are very important for us as an anesthesiologist because we need to evaluate those patients prior to surgery and prepare those patients or optimize those patients before coming for surgery. So perioperative period, you need to evaluate each and every organ system post-chemotherapy or any radiotherapy patients for any organ dysfunction if at all it's present. So coming to the different organ systems which are involved in the chemotherapeutic drugs. So we have pulmonary toxicity, we have anti-tumor antibiotics, alkylating agents, antimetabolites, and plant alkaloids. Cardiovascular systems, mainly your anthracycline groups, doxorubicin and daunorubicin, along with your cisplatins. Hepatobiliary system, mainly the alkylating agents. Renal, you have antimetabolites, especially the alkylating agent cisplatin, which is given mainly for your ovarian tumors. So you need to know those drugs which are going to cause which particular toxicity and need to evaluate those things prior. So coming to individual organ systems, what are the effects on the hemopathetic system? You know that most of the chemotherapeutic agents are immunosuppressants, or they are called myelosuppressions. They decrease your neutrophils, leukocytes, and platelets. So it can cause chronic chemotherapy-induced neutropenia. So what you exactly are going to do when those patients come to you? So you can use for multiple transfusion or reiterated transfusions. You can start with your myeloid growth factors like colony-stimulating factors to boost your neutrophil production. Antibiotics are essential if they are suspecting your secondary infections. Pancytopenias, especially decrease in both your platelets and leukocytes along with your neutrophils. They can decrease, you know that erythrocytes are important for oxygen carrying capacity, so they can cause decrease in oxygen capacity, platelet decrease, risk of hemorrhage, and leukocyte decrease, there are chances of secondary opportunistic infections. So preoperatively, hemoglobin concentration, thrombocyte counts, and peripheral blood differentiation are need to done to exclude pancytopenia. If at all, if there is a severe neutropenia, you need to postpone the surgery until the blood counts recover sufficiently. But if at all, if prolonging neutropenia is too much time period is taking place, you need to have a multidisciplinary approach with the surgeon, hematologist, and your anesthetist along with your granulocyte stimulating factors stimulation so that the surgery is not delayed too far. You know that cancer is also in procoagulant state along with your anti-chemotherapeutic agents. They increase your they are procoagulant, they are antifibrinolytic, pro-aggressive response to lead to venous thrombosis. The procoagulant response is activated through tissue activating factor response, and the risk of thrombosis is more than 6 months after you are given your chemotherapy. So always, usually they are started with anticoagulant drugs. You need to be very careful about your neuroaxial techniques when these patients are coming for any surgeries. Coming to the cardiovascular toxicity, this is one of the paper wherein you evaluated preoperative cardiac evaluation and anesthetic considerations for cancer patients undergoing chemotherapy. They found that cardiotoxicity is one of the most common side effects of cancer treatments, and most commonly the anthracyclines and trastuzumab are the drugs which are very highly effective or causing cardiotoxicity. So this cardiotoxicity can range from your simple ECG changes with your arrhythmias, leading on to cardiomyopathies and myocardial ischemia. So need to be very careful and evaluate those patients post-chemotherapy. So I told cardiovascular can be atrial fibrillation, cardiomyopathies, myocardial ischemia, and the most common drugs are alkylating agents. So what do? You know that whenever there is damage to the cardiac, there is limited time to repair, or there is no time for the cardiac myocytes to regenerate. So once this damage is done, so the chances of myocardial infarction, LV dysfunction, and arrhythmias and heart failure are very high. This is one of the patients which we have found that post chemotherapy with doxorubicin and daunorubicin, and we found that we did an echo that he had a severe LV global hypokinesia with the LV dysfunction and pulmonary hypertension. So we need to evaluate, even the patient looks normal, but still that we need to evaluate the echocardiography, and required, you need to do further evaluate further. So what you are going to do, you are going to do a focused history and examination, exploring the signs and toxicity of your cardiac toxicity, preoperative ECG to see any changes. 2D echo is a must for all chemotherapy patients to evaluate any regional wall motion abnormalities or ischemia. If required, if there are any abnormalities, you need to go further to evaluate with your laboratory test with pro-BNP and your troponins. And always suspect and treat the patients with cardiologists so that you stabilize the patient and optimize prior to the surgeries. Coming to pulmonary toxicity, the pulmonary toxicity can range from your simple interstitial pneumonitis to lung fibrosis, and it can cause all ARDS also. So the most common drugs are your alkylating agents. Cytotoxic drugs, main mention, the bleomycin and your mitomycin. The bleomycin is most commonly used for the solid tumors, especially are very hazardous, and they can cause lung fibrosis. So be careful when you're dealing with poor patients coming with post-bleomycin. So especially when you're giving the bleomycin concept drugs more than 400 international units per meter square, life-threatening pulmonary fibrosis can develop in 5 to 16% of the patients. Lung injury develops within 6 months of the start of bleomycin therapy. What you're going to look is you need to evaluate those patients with pulmonary function tests, and you need to know that what is the diffusion lung capacity of the carbon monoxide, so that you decrease the concentration of FiO2, which is because high FiO2 can further aggravate your lung fibrosis and damage. So physical examination they can usually present with cough, low-grade dyspnea, hypoxemia, and low-grade fever. So on examination, you can find bilobasal crypts, and on X-ray, you can find your reticular shadowing or ground glass opacities. High resolution CT is not sensitive but not specific, but as a prognostic value is not unclear. So as I told, PFT has to be done for all patients coming for with post-bleomycin toxicity coming for surgeries. So what is the differential diagnosis? You can give a dose of steroids and stopping the bleomycin treatment and other supportive measures to treat those patients. And when you do intraoperatively, when such patients come for you, you target your SpO2 around 88 to 92% with low FiO2 as low as 30% should be sufficient. And postoperatively, without oxygen, if it is maintaining saturation more than 90% should be good enough. Coming to renal toxicity, we have acute kidney injury, the most common with proximal tubular damages. The most common are alkylating agents with cisplatin and busulfan, which are most commonly used for, again, ovarian tumors. They can cause acute kidney injury, decreased urine output. So what you are going to look is, you evaluate your renal function test, increase creatinine levels, and see that intraoperatively you maintain a good fluid balance, avoid nephrotoxic drugs as much as possible. So I told cisplatin is the most widely used chemotherapeutic agents. The decreased GFR, increased creatinine, and magnesium wasting is almost common with this drug. Coming to liver toxicity, what you're going to liver toxicity, again, it can be a simple elevation in the liver enzymes, leading on to your steatosis and your increased chronic liver damage. All these are common complications of liver toxicity. And again, the combination, all chemotherapeutic agents involve one or more organ systems which can affect these systems. So always evaluate holistically when you treat with post-chemotherapeutic patients. I told inflammatory steatosis, cholesteatosis, and end-stage liver disease are more common. So preoperative, what you're looking for? You're looking for your LFT, serum enzyme levels. If it's a mild preoperative liver dysfunction, should be managed with observation and good care of your avoiding hepatotoxic drugs. Severe derangement requires risk stratification, and especially if there is coagulation abnormalities, try to avoid how you balance your neuroaxial blockades. Coming to central nervous systems, usually they are dose dependent. It depends on cumulative dose and dose intensities. And other risk factors associated are your diabetes mellitus, increased age, and along prior treatment with other neurotoxic drugs can be additive for your chemotherapy-induced toxicity. So it can cause peripheral neurotoxicity or central neurotoxicity. Peripheral neurotoxicity, usually they start predominantly when you start your chemotherapy. When you stop your chemotherapy, the peripheral neuropathy usually subsides. So what you need to know is, along with your peripheral neuropathies, you need to look at autonomic dysregulation, especially when you're giving your chemotherapy drugs. So it's a range of central neurotoxicity starting from encephalopathy, cognitive dysfunction, hemiparesis, and dementia. This is one of the paper of BJ again, where they found that preoperative consideration in patients who undergo chemotherapy and cognitive impairment, along with the pre-existing patient factors, they have found that certain anesthetic factors and surgical factors also involving in cognitive impairment. It's like chronic use of your benzodiazepines, long-acting opioids, post-operative pain, the more important factor, your ICU stay, prolonged ICU stay, along with your surgery, how long your surgery and what type of surgery, and the duration of surgery, all were involved in post-operative cognitive dysfunction, especially in these chemotherapeutic patients. So what you need to do, you need to have a good comprehensive neurological examination and should be performed and documented. And when you're using a regional anesthesia, is not contraindicated, but see that your pre-existing neurological abnormalities are documented prior. Now coming to effects of radiotherapy. Now radiotherapy is one of the important treatment modalities of cancer. We know that with the innovations, we have stereotactic radiotherapy, adaptive radiotherapy, and IGR, image-guided radiotherapy treatment options. What exactly the radiotherapy do? They damage the double-stranded DNA and kill the cancer cells, and replicating them further leading to cell death. So what are the effects of radiotherapy? The radiotherapy effects can be, it's usually a targeted site, so the targeted sites are involved. It can start with generalized skin reactions. It can go on to different organ systems in and around whatever the radiation therapy is given. So immune system, irradiation results in pro-inflammatory response. It leads to immunosuppression and decrease in natural killer cells. It affects the vascular endothelium, increased permeability with increase in dosage. So again, I told chemotherapy, it's not only procoagulant, even the radiotherapy can increase your thrombosis and because of platelet aggregation and fibrosis. So on the cardiovascular system, if at all radiation is in and around your cardiovascular system, the constrictive pericarditis is the most common symptoms. Always evaluate for post-radiotherapy coming for your surgery. Have an echo done, see for constrictive pericarditis, along with your rhythm disturbance and QT prolongations. Pulmonary edema, fibrosis, and pneumonitis are complications of post-RT. This is one of the patients which had come for us post effect on radiotherapy on head and neck. So we found that these are the side effects along with your trismus, dysphagia, changes in airway, and hypothyroidism. So you should, especially post head and neck therapy, you need to evaluate your airway very properly because there can be chances of difficulty in mask ventilation and difficulty in laryngoscopy. And difficulty in laryngoscopy, this is one of the patients why this. You can see here the post radiotherapy, the patient is not able to protrude the tongue. And the same patient, when we did our video laryngoscopy, we can see that the epiglottis is so thick and edematous that we are not able to, with external manipulation also, we are not able to bring that laryngeal axis in pharyngeal line. So always do a good airway, even if though Mallampati grade 1 and 2 or 2, see that post-radiotherapy are very common causes for airway difficulties. Again, this is again one of your article where in the head and neck therapy and the risk of anesthesia was very high. So because, just 2 minutes, because post-RT, we always, during head and neck surgeries, we need that hypothyroidism is one of the common complications post-radiation because of the high thyroid radiation. So always evaluate your TSH levels prior to this one. Anything less than 15 should be good enough for a patient to undergo surgery along with your endocrine opinion. Immunotherapy, again, the immunotherapy are different the therapies. We have immunocheckpoint inhibitors like interferons, and also you have your chimeric antigen T cell receptors. So usually they have an effect on the chemotherapy on the patient, but they're all not much as your chemotherapy or radiotherapy. So what you are going to do is preoperatively you have to do an endocrine and cardiac and pulmonary toxicity evaluation. You need to know what agent has been given and what are the toxicity that is involved. So the most common complications are cardiovascular toxicity and endocrine, especially your hypophysitis, pituitary damage, hypothyroidism and endocrine deficiencies. So to management, you need to assess the patient very carefully. Timing of the surgery is most important. Prehabilitation is very important, especially it increases your physical performance and reduces complications. So prehabilitation can include your nutrition support, pulmonary rehabilitation, correction of anemia, preoperative counseling and treatment of COPD. So the timing of surgery depends on how, you cannot give more time for recovery because the surgery itself is a main store of treatment. So ideally 4 to 6 weeks should be good enough to give a time period to recover the patient. So evaluation, so again the cardiac I told us what you are going to intraoperatively, either a general or regional anesthesia should be good enough, but whatever technique you use, see that it's, and you know that what are the toxicity that are involved and target according to that. So interaction with anesthesia is very less. So all anti-neoplastic drugs and chemotherapy anesthetic drugs, they're poorly understood and publicized. So not much of interactions can be found, especially only few with lignocaine and bleomycin and succinylmethamine and cyclophosphamide. Usually other than that, we don't have any interactions with this one. So the key points, prehabilitation is most important. It improves your physical performance and reduces complications. Always extending the time of surgery has negative consequences for survival of cancer and no benefits from reducing complications. Neoadjuvant chemotherapy has a toxic adverse on different organ systems. Neoadjuvant therapy affects the target organ but has systemic effects also. And radiotherapy, when a patient coming for head and neck cancer, always try to see that you evaluate your airway thoroughly, and because difficult airway management, unanticipated difficult airway is very high in post-RT of head and neck cancers. To conclude, so careful consideration to potential organ toxicity and reduced functional capacity. You need to have a multidisciplinary approach, prehabilitation, preoperative, good preoperative assessment, and crucial to optimize patient outcomes and minimize post-operative complications. Thank you.
Thank you, sir, for that comprehensive look at the evolving challenges of anesthetizing patients undergoing neoadjuvant therapy. Moving on to the next talk, our next speaker is